Good evening, students. Greetings to you from Sri Rama Hospital. We're going to discuss about the anatomy of surgical anatomy of thyroid gland. Thyroid gland, as you look at it, it looks like that of the shape of the butterfly. Why is it called thyroid gland? Anyone tell me? The meaning of thyroid gland, but the word is from Latin. So, why is it called thyroid? Do you know the actual meaning of thyroid gland? Okay? The meaning of thyroid gland is not butterfly. It is she. The first one that was found in the human body in relation to thyroid gland was thyroid cortex, not thyroid gland. So it is like a shield in front of the larynx. Larynx will be here and vocal cords. So in front of it is like a shield, it will be there. But the shield means it is not like guarding, a shield that is used in the walls. So that's why it is likened to that of shield. And so it is called as it was called as the thyroid, because the gland is there just in front of it or just by the side of it. The gland also got the name of the thyroid, so it was called the thyroid gland. When you look into the history, you will be surprised to know that Galen in 2nd AD, he postulated that the thyroid gland is actually it looks like a gland, but he was unable to find a duct. What he thought that the secretions will be going directly into the larynx. The people asked him why the secretion should go inside. He said that to lubricate the larynx while speaking. So that was what he said, and almost for about 10 or 12 centuries, the same thing has been followed by many of the anatomists and physiologists. Of course, there were no anatomists and physiologists during those days. So by custom, people used to think that thyroid gland is for lubrication of the glands. Theodore Cocker and Theodore Billroth. The two are contemporaries, and actually Theodore Billroth was the professor of surgery in Vienna, and Cocker worked as assistant for him for a few years, and both of them had pioneered the surgical management of thyroid disease in 1880s to 1900. Actually, Cocker has ruled the surgical world of thyroid diseases. So before Cocker, the mortality for thyroid surgery used to be around 50 to 70 or 80%. His meticulous understanding of anatomy, physiology, and surgical technique has brought down the mortality rate to 0.3%. So you can imagine the great knowledge of Cocker and skills of Bill Roth. A thorough understanding of thyroid anatomy is central to the performance of a safe thyroid surgery. If you want to become a good thyroid surgeon means you should understand thyroid anatomy. Unless you know it, you can't perform a safe thyroid surgery. This is the surface anatomy of the thyroid gland. This is the lower border of the mandible. Here is the symphysis menti. From here, the neck starts. These are the submandibular triangles, and the trachea is there in the midline along with the larynx. Here is the hyoid bone. This is the thyroid cartilage. Below this is the cricoid cartilage, and below this we have the tracheal rings. This butterfly-shaped organ is situated as if it is hugging the trachea and going to the sides as well as little superiorly even to the thyroid cartilages. There is an optic line of thyroid cartilage. Up to that it can extend. It lies over the second and third tracheal rings usually. Sometimes, or in some people, it may lie over the third and fourth tracheal rings. The lower pole of the one lateral lobe will extend up to sixth tracheal ring. So these three cartilages you should know. So this is the hyoid bone, this is thyroid cartilage, this is cricoid cartilage. So these are the bony and cartilaginous landmarks to understand the anatomy of the thyroid gland. First of all, let us see all the layers of the neck. Then you can understand exactly the anatomy of the thyroid gland. Are you able to hear me properly? Someone has given me a message that voice is not clear. Okay. So what is this muscle? Once you remove the skin, this is the skin. Yes, this is the platysma. Next to the platysma, what do you get? Actually, the superficial fascia of the neck has little subcutaneous tissue and has much of this platysma. So once you remove the platysma, you will get the deep fascia of the neck. This is also called the cervical fascia of the cervical fascia or Colles fascia. How many parts are there from cervical fascia? How many layers are there? What are they? If you want, you can speak out in your mic. Okay, general misting layer. Other is prevertebral layer, and third one is the pretracheal layer. Very good. So there are three layers. The general misting layer invests all the muscles in circumferential manner. It starts from behind the spine, attached to the spine in the center, and encircles around the neck. While it's encircling around the neck, it encloses the sternocleidomastoid on either side. And superior border is attached to the inferior angle of the mandible. inferiorly, it is attached to the clavicles and sternum. Where it is attached to the sternum, in the midline, it actually splits into two layers. You can see here. This is the sternum, this is the mandibular sternum, this is general listing layer. So as it comes down, it splits into two layers to attach itself to the anterior border as well as posterior border of the mandibular sternum. So now there is a space here. This space is known as the space of Barnes. What structures are there in the space of Barnes? Tell me this. Space of Barnes also is an important short notes question in the examination. No, it is not subclavian vein, it is not pretracheal lymph nodes. What is vein? You are seeing one vein here. Pair of veins. Sometimes it will be single, sometimes displayed. This is called the anterior jugular vein. So it has a communication between the two anterior jugular veins. It has fats, and the space of Barnes has 2 or 3 lymph nodes. The importance being, the space of Barnes may get a lipoma. The space of Barnes may have tuberculous lymphadenitis. The space of Barnes may have a swelling of dermoid of the neck. So whenever you find a spherical swelling in this region, then you must think of these conditions: a cold abscess, dermoid of the anterior or midline dermoid of the neck, or tuberculous lymphadenitis, or a lobular swelling means, lobulated swelling means you think of lipoma. So this is the general listing layer. This is trapezius muscle behind, enclosed in the general listing layer. This is the sternocleidomastoid in front. So circumferentially, the neck is surrounded by this general investing layer of the deep fascia of the neck. Now, if you look at here, just deep to the posterior border of sternomastoid muscle, we have 3 structures. Superficially a vein, then an artery, and posteriorly a nerve. This is the carotid artery or common carotid artery. This is the intrajugular vein, and here is the vagus nerve. Now, the general listing layer of the fascia of the neck, it gives off 2 layers medially. One layer goes in front of the trachea, another layer goes behind the esophagus. Here is the trachea and here is the esophagus. So these 2 are called the viscera of the neck. In the neck, these are only 2 viscera. One is trachea, another is the esophagus. And of course, the third one is the thyroid gland. So these 3 are the viscera of the neck. So you can look at here, the visceral compartment of the neck is enclosed in between these 2 layers. Anteriorly, the pretracheal fascia, posteriorly, the prevertebral fascia. This is the vertebral body, and this is the prevertebral fascia. This pretracheal fascia, it comes in front of the great vessels of the neck and passes medially, splits to enclose thyroid gland between the 2 layers. Because this pretracheal fascia arises from this particular area. Here you can see this carotid artery is anteriorly lined by pretracheal fascia, posterior prevertebral fascia. So almost there is a circular facial covering for the carotid vessel, intrajugular vein, and vagus nerve. So this is called as the carotid sheath. If the thyroid gland enlarges, then it goes like this laterally. Because the critical fascia is coming from the deeper surface of sternomastoid, the thyroid gland will go always deep to the sternomastoid. Whenever you find a swelling in the neck, which lies in front of the sternomastoid, you should think of some other condition, not the thyroid gland. Though it looks lobular, you should think of only some other condition, not the thyroid gland. Once you remove the jungle loosening layer, you will find these muscles. So you see one long longitudinal muscle here on either side, and one muscle is going obliquely. So can you tell me the name of this muscle, this longitudinal muscle? Of course, they are called the strap muscles. Can you specify the name of this muscle? Very good. Very good. Sternohyoid. What is oblique muscle? Superior belly of what? Omohyoid. Very good. Okay. The superior belly of the omohyoid. And once we take away these two muscles, then let's see what is there deep to these. The omohyoids have been taken away. Now we are seeing the sternohyoid, which is extending from the mandibular sternum and going up inserted into the hyoid bone. You can see the thyroid cartilage here peeping in between the two sternohyoid muscles. Now I will remove the sternohyoid muscle also. Now what you are seeing here? Actually you are seeing two muscles in succession. This is one muscle and this is another muscle. This muscle, the lower muscle or inferior muscle, is called as the sternohyoid. Very good. And superior one is called the thyrohyoid. Very good. So this is sternothyroid and this is thyrohyoid. This is the oblique line of the thyroid cartilage. The thyroid gland lies deep to this inferior muscle, is sternothyroid muscle. So if thyroid gland enlarges, it enlarges only up to the oblique line of the thyroid cartilage. It can't go beyond that because the muscle is here. It prevents it, which is attached here, prevents it from going upwards farther than this. So if you see a swelling which is going up almost up to the angular mandible, then you must think of some other condition, not this thyroid gland. Now we have removed the thyrohyoid muscle also. You are seeing this thyroid cartilage, it is just like a sheet. Once you remove the other muscle also, you see a thin layer of fascia. This is the pretracheal fascia. This is attached to the thyroid cartilage. It's coming from the carotid sheath. So here is the carotid vessels, and from the carotid sheath, it is arising and comes in front, and it's coming in front of the thyroid gland. Of course, one layer goes behind it. So lateral extent is from the carotid sheath. Upper extent is to the thyroid cartilage, and lower extent. So lower, what is the attachment of the pretracheal fascia? To what structure it is attached? Do you know or no? It is not attached to the sternum and clavicula. This pretracheal fascia descends down into the behind the sternum, where it goes into the superior mediastinum. It goes into the superior mediastinum and merges with the pericardium there. This anatomical point is very, very important to understand the retrosternal goiter. For example, just now I said it is enclosed, thyroid gland is enclosed between the two layers of the pretracheal fascia. The thyroid gland enlarges. What will happen? These two layers, they just gives way for the thyroid gland which is enlarging. So the thyroid gland gradually descends down, 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 comes to the sternum. Because the pretracheal fascia is not attached to the sternum, it goes behind the sternum into the superior mediastinum. So when thyroid gland is enlarging, the pretracheal fascia just gives way for the thyroid gland to extend deep into the behind the suprasternal notch. So it can go into the superior mediastinum. Had this pretracheal fascia been attached to the sternum, for example, suppose, then no one can have a retrosternal goiter. Retrosternal goiter is present because of this anatomical attachment of the pretracheal fascia to the pericardium after going behind the sternum. So you have to remember this point. And another important point here is this one. Because the pretracheal fascia attaches itself to the thyroid cartilage as well as thyroid gland. So whenever a patient swallows, the thyroid cartilage moves upwards. So it pulls the pretracheal fascia upwards. So this pulls the thyroid gland also upwards. Of course, this is not the only structure that causes movement of the thyroid gland while swallowing. Many of the examiners in clinicals ask you this question. What structures move on swallowing? Tell me. What swellings move on swallowing? Okay, thyroglosal cyst. Lymph nodes. Specify the lymph nodes. What lymph nodes? Subhyoid is not abscess, actually, it is subhyoid bursa. Some people who use their voice very frequently, like teachers, singers, there may be small bursa under the hyoid bone. That's called subhyoid bursa. Okay. Level 6 lymph nodes. They are also called as the pretracheal and prelaryngeal lymph nodes. So the structures that move on swallowing are the thyroid gland, thyroglosal cyst, pretracheal and prelaryngeal lymph nodes, subhyoid bursa. So these four you must always remember. This is very, very important. Even when you are sleeping, if someone wakes you up and asks this question, you must be able to tell these four immediately. The next question will be the common question in the clinical is why the thyroid gland moves on swallowing. Number one is this pretracheal attachment, pretracheal facial attachment. There are other factors also are there which are responsible for the movement of thyroid gland during swallowing. Can you tell me? Very good. The most important structure is the Berry's ligament. Of course, in the course of this anatomy, now I will tell you of some time what is Berry's ligament and where it is situated. Okay, any other thing? Berry's ligaments then? Though pretracheal fascia is divided split into two layers to enclose the thyroid gland, the deep layer, that is between the thyroid gland and trachea, it is almost gets amalgamated with tracheal surface. That is why what happens is the thyroid has indirectly got an attachment to the trachea. So because of the attachment of the pretracheal fascia deeper layer to the trachea, and attachment of the thyroid gland to the pretracheal fascia. This binding of there will be indirect binding to the tracheal rings. So during swallowing, the tracheal rings also move upwards. So the thyroid gland also move upwards. So once you take away the pretracheal fascia, now you can see actually the external surface of the thyroid gland. Good number of veins will be there coursing over the surface of the thyroid gland. They are very thin walled. So because they are thin walled, sometimes they are fragile also. While you are doing dissection to separate the thyroid gland from the strap muscles of the neck, that is sternohyoid, sternothyroid, then there will be sometimes bleeding from these veins. And lateral to the thyroid gland, so this is the lateral border. And lateral to the thyroid gland, you can see a large vein. This is the internal jugular vein. And you can see here, this is subclavian vein. And this is the internal jugular vein, and this is the subclavian vein. This is the common trunk, that's called brachiocephalic trunk. Now you can see here, this venous plexus that is situated over the thyroid gland drains ultimately by three veins. One vein going upwards, one vein going laterally, another vein going inferiorly. This vein which is going upwards is called the superior thyroid vein, and it is in association with the superior thyroid artery. This is called the inferior thyroid vein. Sometimes it may be single, many times it may be paired. That means two veins will be there, one on either side. And this is the middle thyroid vein. The superior thyroid vein drains into internal jugular vein. The middle thyroid vein again drains into the inferior thyroid vein, internal jugular vein, and this inferior thyroid vein drains into what? The brachiocephalic vein. And once you remove the true capsule of the thyroid gland, thyroid gland is having two capsules. One is true capsule, other is the false capsule. True capsule is the condensation of the parenchyma of the thyroid gland. False capsule is nothing but the pretracheal fascia. Now you can see this is the true capsule of the thyroid gland after removal of the pretracheal fascia. And you can see the arteries now. Here we don't find the inferior thyroid artery accompanying the inferior thyroid vein, but the inferior thyroid artery is situated on the lateral side, lateral and posterior side. And this is the superior thyroid artery. The superior thyroid artery arises from the external carotid artery. This is the first branch of the external carotid artery. And inferior thyroid artery arises from posterior. Tell me. Which vessel? Inferior thyroid artery arises from thyrocervical trunk. Very good. Thyrocervical trunk is a branch of thyrocervical trunk is a branch from subclavian vein. Very good. So many of the students, yes, they may say in common carotid artery by mistake. So inferior thyroid artery arises from thyrocervical trunk, which is a branch of the subclavian artery. It is not from the internal carotid artery. So please remember this point. Once you remove the thyroid gland, then you can find the tracheal rings here. And you can find the nerves. Now you can see this particular nerve is descending down like this. This thick nerve. This is situated posterior to the carotid artery. Of course, internal jugular vein is here. This is also removed. That means in the groove between the internal jugular vein and common carotid artery, posterior to them, you find this nerve. This is the vagus nerve. It's not glossopharyngeal, it is the vagus nerve. The vagus nerve descends down like this It is also enclosed with keratin sheath. This is down like this and enters the thoracic cavity. And later, of course, goes into the abdominal cavity also. Do you know why it is called vagus? What is the literal meaning of vagus? How it got its name? Of course, it's long. Wandering, very good. Actually, the word is derived from vagabond. Vagabond means who is wandering everywhere. So you see him here, then in some other place, then if you go to see a picture, so a cinema hall, you will find him there. If you go to a restaurant, he will be there. So then you call him as a person who is wandering all around. That means he's a vagabond. So this vagus nerve is a vagabond. It is there in the cranium, neck, thorax, and abdomen. So wherever you go, this vagus nerve is there. Okay. This vagus nerve, we are interested in this because when it's coming down like this, it goes behind the subclavian artery. Subclavian artery is going here like this. Okay, this vein is coming in front. That's why I'm not able to see it, appreciate it properly. The subclavian vein goes like this on the right side. This vagus nerve comes behind this subclavian artery. Then it hooks, so it gives off a branch that's called the recurrent laryngeal nerve branch before it goes behind subclavian artery. This nerve, what it does is it comes in front of the subclavian artery, then hooks around it. You can see it, the nerve is here, it's coming like this, hooking around it and going again medially, just lateral to the tracheal veins. It goes in between the trachea and esophagus. So this is called the recurrent laryngeal nerve. The recurrent nerve starts from the subclavian artery, goes behind it, and courses in the tracheoesophageal groove upwards. Thyroid gland has two lobes connected by anesthemus. It is situated in front of the trachea, enclosed in between the two layers of pleuritic fascia. Hence, it moves on deglutition because of its enclosure in the pleuritic fascia, which moves with swallowing. As the pleuritic fascia rises deep to the sternomastoid muscle, the thyroid gland always lies deep to the sternomastoid, however large it may be. As the pleuritic fascia extends to the superior mediastinum, thyroid can also extend to the superior mediastinum if the gland enlarges downwards. Then it is called the retrosternal extension. The whole gland develops, enlarges in the thorax, then it's called the retrosternal goiter. So this is the depiction of the blood supply to the thyroid gland. This is the common carotid artery. This is subclavian artery. This is the intrajugular vein. The common carotid artery at the upper part of the thyroid cartilage divides into two branches. One is the external carotid artery, other is the internal carotid artery. The first branch of external carotid artery is superior thyroid artery. Can you tell me the branches of common carotid artery apart from these two? Apart from external carotid and common carotid, external carotid and internal carotid, what are the other branches of common carotid artery? What are the other branches? The next question is, are there any branches to the common carotid artery or not? Are there any branches to the common carotid artery? There are no branches to the common carotid artery except its two terminal branches. What are the branches of internal carotid artery extracranially? Outside the cranium, what branches are there for the internal carotid artery? it also has no branches. Why I must put this question is, in some of the tumors of the head and neck, large tumors, malignant tumors, when you are going to operate, so the surgeons will ligate the external carotid artery before proceeding for surgery of the oncological work on the head and neck. So they want to ligate the external carotid artery to reduce the vascularity and bleeding in the site of the operation. Okay. Now, to ligate the external carotid artery, what they do is, before ligating this vessel, a major vessel in the neck, they check whether it has branches or not. The only carotid artery which has branches is the external carotid artery. If it has no branches, means it can be either common carotid artery or the internal carotid artery. So they put ligature after they identify two branches, and in between the two branches they ligate it. So that the dictum of application of a ligature to reduce vascularity in head and neck surgery. So when you are ligating it between two of its branches, means you are sure that you are ligating only external carotid artery. Did you understand my point? Okay. External carotid artery only has branches in the neck. So this is a common carotid artery. See here. Can you see me? My video is visible or not? Not visible. Okay. Okay. This is the common carotid artery, and this is the internal carotid artery. I am drawing here. Are you able to see here? Okay. And the external carotid artery gives of branches. I hope all of you know the branches of the external carotid artery. They are superior thyroid, ascending pharyngeal, lingual, facial, behind occipital, then postauricular, divides into two terminal branches, superficial temporal and internal maxillary. So, external carotid artery has the branches. Internal has no branches, common carotid has no branches. For example, a patient is having a large malignant tumor of the parotid gland. It is very vascular. Then what the surgeon wants to do is, before doing dissection of the parotid gland, he wants to ligate the external carotid artery. So he makes an opening in the neck. He finds an artery that's pulsating, big pulsating artery, that's carotid artery, and he wants to apply ligature. Whenever he wants to apply ligature, he has to apply ligature to a vessel which is bearing branches, and he will apply ligature between the first branch and second branch. Not below this and not above this. So if he is ligating here, means he is very sure that he is ligating a carotid artery which has the branches. Do you understand my point? He should not ligate common carotid artery, should not ligate internal carotid artery. What will happen if he ligates common carotid artery or internal carotid artery? By mistake, he put a ligature over the common carotid artery. What will happen? Is it harmful or not? So no perfusion of the brain on that one side. So the patient will get contralateral hemiplegia. So that's why common carotid artery and little carotid artery should not be ligated under any circumstances. If you want to do some surgery on the common carotid artery and little carotid artery, then you have to put an external shunt between common carotid artery and little carotid artery, or arch of aorta and little carotid artery, and then you have to do surgery on the common carotid artery. Otherwise, you should not do. You should not put a clamp there, and you should not do any ligature or surgery on the common carotid artery without putting a pre-op shunt. So, common external carotid artery only has the branches. That is why whenever you want, you have to ligate a vessel, ligate the carotid artery. That is, you ligate only external carotid artery. That means you choose a carotid vessel which has branches and ligatures. Okay. So this is the external carotid artery. The branch is superior thyroid artery. The superior thyroid comes to the superior pole of the thyroid gland, divides into multiple branches. Sometimes it divides even before coming to the superior pole of the thyroid gland and distributes to the supplies to the parenchyma of the thyroid gland. The importance of the superior thyroid artery is it is accompanied by a nerve. What is nerve? Yes, it is external laryngeal nerve. A branch from superior laryngeal nerve. This is the vagus nerve. The vagus nerve gives off superior laryngeal nerve, a short branch. It goes behind the external carotid artery and divides into two branches. And internal, superior laryngeal nerve continuation as the internal laryngeal, it is the internal laryngeal nerve, and this is the external laryngeal nerve. The main trunk is the superior laryngeal nerve. So it has an internal branch and an external branch. The internal branch pierces the thyrohyoid membrane and it supplies the what? I think all of you have to appear for ENT or you have passed out of the ENT. Yes, very good, very good. Sensory to the upper glottis, sensory supply, very good. Sensory supply above the larynx, well, wonderful. What is motor supply? To which muscles it supplies? Internal laryngeal nerve supplies which muscles? I repeat the question again. Internal laryngeal nerve, branch from superior laryngeal nerve, supplies which muscles? Only one has given correct answer. All the other has given wrong answers. Internal laryngeal nerve has no motor branches, either within the larynx or outside the larynx. It has only sensory supply to the larynx above the vocal cords. That means piriform fossa, epiglottis, arytenoid cartilages, posterior one-third of the tongue, and vellecula. So these are the places that are supplied by, innervated by the internal laryngeal nerve, which is a branch of the superior laryngeal nerve. The external laryngeal nerve, it supplies what structures? This is external laryngeal nerve. Actually, it is accompanying the superior thyroid artery. It supplies which muscle? It supplies only one muscle, that is cricothyroideus. cricothyroides. If you get a thyroid case, the first thing what you should do is you should recapitulate the anatomy of the larynx, its nerve supply, the muscles of the vocal cords, the movements of the vocal cords, and what happens if the nerve supply is denervated, what movements will be absent. All these things you should know thoroughly. The importance of thyroid surgery is a very small gland. It weighs only about some 20 grams. It occupies one full chapter in surgery. It is one of the most important topics for the undergraduate and postgraduate students of surgery. Almost 90% of the students, they get a case of thyroid in the examination, clinicals. Either as a short case or as a long case, usually as a long case. So you should be thorough in and out about anatomy of thyroid gland. And of course, about the anatomy and functions of the vocal cords and larynx. If thyroid gland is not related to these nerves, ectolaryngeal nerve and internal laryngeal nerve or external laryngeal nerve, we need not bother about thyroid gland surgery at all. It's just like a lymph node dissection. You make a skin incision, hold the gland, drag it, put all arteries around, cut it, take away. So within 5 minutes, the thyroid surgery is over. That would have been the thing. But for the nerves, so to protect the nerves, you do a meticulous dissection. That may be 1 hour, 3 hours, or 5 hours, depending upon the disease and then attachments, additions, etc., etc. That's correct. Okay, let's come back. Superior laryngeal nerve divides into internal laryngeal nerve, which is the thyroid membrane. It is totally sensory to the upper part of the larynx and posterior wall of the upper pharynx. The other branch is called the external laryngeal nerve. It accompanies the superior thyroid artery. It runs medial to the superior thyroid artery and it lies between the superior thyroid artery and thyroid cartilage and cricothyroids muscle here. And it crosses the thyroid cartilage and then innervates to the cricothyroides muscle. That means the muscles situated between the cricoid cartilage and thyroid cartilage. What is the function of this muscle? Whenever you are doing surgery around the superior pole of thyroid gland, sometimes this nerve may be injured. That means the external laryngeal branch of the superior laryngeal nerve. It may be injured. If this nerve is injured, then this muscle will be paralyzed. That's what will happen. Very good. It is tensor of the vocal cord. So what will happen? The tension is lost. So will there be hoarseness? If this external laryngeal nerve is injured, will there be any hoarseness? Actually, it is not hoarseness. The vocal cords normally are tense. When they become this particular external thyroid, external laryngeal nerve is injured, then what will happen is this cord will become flabby. The tensor of the vocal cord, so that means this cricothyroids muscle acts as a tensor of the vocal cord. If it is paralyzed, means the tension of the vocal cord is lost, it becomes flabby. So the pitch of the voice is changed. For example, you see a veena, the veena will have a lot of strings. If you tighten it, the wings become tense. Then you will get one type of note. If you loosen the strings, then you will get another type of note. If you want to get a high pitch voice, you have to tighten the strings. So the string will become too tight, and once you string it, strike it, you will get a high pitch note. If you loosen it, you will get a low pitch note. Similarly, the quality of the voice is lost if cricothyroid muscle is damaged. It is not aspiration. The hoarseness of voice occurs if two vocal cords doesn't meet one another in the midline. That happens when the vocal cord intrinsic muscles are paralyzed. Cricothyroides is called as the extrinsic muscle of the larynx. It is not within the larynx, it is outside. It is situated between the thyroid cartilage and cricoid cartilage outside, not within the larynx. Within the larynx, the vocal cord has some muscles. If these muscles are damaged, then what happens is the movement of the vocal cord will be absent. So when person is speaking, they should come in midline and then go away like this. So this is what we see during speaking. But if one who is moving, other is static like this, so then the person will get the hoarseness. So that means all the intrinsic muscles of the larynx, I said intrinsic muscles, all the intrinsic muscles of the larynx are innervated by the recurrent laryngeal nerve, the other branch of larynx. So only in recurrent laryngeal nerve injury, the patient will get the hoarseness of voice or asphyxia or difficulty in breathing. Okay, we'll come to the point now. So what about, for example, if the person is having a superior thyroid pole, is having a large mass here. So when a large mass is there, you have to dissect it more posteriorly. When you are dissecting more posteriorly and superiorly, you may injure the main superior laryngeal nerve. Sometimes even the external laryngeal nerve branch may be injured. Sorry, the internal laryngeal nerve branch may be injured. If the internal laryngeal nerve is injured during your thyroid dissection, what the problem the patient will have? What problem the patient will have? Very good. There will be aspiration. Why there is aspiration? Whenever the patient is swallowing, if he swallows very rapidly, then he cannot perceive the proper sensation of swallowing. So the food particles or water droplets may enter the larynx and that may produce a constant cough. So the fellow will be getting aspiration, pneumonitis, tracheitis, laryngitis. So all sorts of problems the patient will face because of this aspiration. The patient doesn't have any motor problem with the larynx. He will be speaking normally, but the patient will have this problem of aspiration, and that is not at all corrected throughout life. In many cases of sensory nerve damages, what will happen is, the sensory nerve is damaged, the other dermatomes, over a period of 3 to 9 months' time, they overlap and they will cover that particular area, they migrate to the particular area, the branches, and the anesthesia part will gradually diminish. But here, for the mucosa of the larynx, if one internal laryngeal nerve is damaged, the sensation is permanently lost and the patient will be a wreck for life. So whenever the patient swallows water or foods, there is risk of getting aspiration and chronic cough. Okay, this is about the superior laryngeal nerve branch. We have seen this vagus coming down like this and is giving off this branch. This is the recurrent laryngeal nerve. So this recurrent laryngeal nerve goes medially on the lateral side of the trachea. It travels in the tracheoesophageal groove, and it ascends behind the thyroid gland, then enters the larynx by piercing the cricothyroid membrane. So we'll study a little more in detail about this little while later. So the blood supply of the thyroid gland, arteries, superior thyroid artery. Second one is the inferior thyroid artery. There are only 2 arteries on each side, superior and inferior. The venous lineage, superior thyroid vein, middle thyroid vein, inferior thyroid vein. There are three veins. Occasionally, there may be a third artery coming from direct from the arch of the aorta or from the left subclavian artery. This is called as the thyroidea ima. Yes, very good. Thyroidea ima. This is present only in about 3% of the individuals. So many of the persons do not have this thyroidea ima artery. So it is there only in about 3% of the individuals. So when you look from behind, this is what you see. This is the common carotid artery dividing into internal and external carotid arteries. External carotid artery is giving off the superior thyroid artery. You can see here the superior laryngeal nerve dividing into, this is the internal laryngeal branch, and the other one is the external laryngeal branch. It accompanies superior thyroid artery and supplies to the cricothyroid muscle. And whereas descends down like this and passes down in front of the subclavian artery into the thoracic cavity. And here is the recurrent lesion of passing like this. Now, when you are doing surgery to the thyroid gland, where do you put the ligature to safeguard this external laryngeal nerve and internal laryngeal nerve? Internal laryngeal nerve usually is not in danger because there is a lot of distance between the superior thyroid pole and the internal laryngeal nerve. The danger to the internal laryngeal nerve occurs only in case of the glands which has enlarged superiorly and more posteriorly. So that means superior pole lesions. A large nodular goiter, solitary nodule, mass arises from the superior pole of thyroid gland. So almost occupying here. Then this nerve will be in danger. Other cases, this external laryngeal nerve branch is in danger most of the times. So what happens is, if you look at the superior thyroid artery, this is superior thyroid artery. The nerve is coming here and close proximity to the artery, superior thyroid artery, near its origin. As you come down, the artery is going like this, the nerve is separated from the artery. So, you tell me, where do you want to leg it? You leg it higher above or lower above? Where do you leg it? Tell me. Yes, good. You leg it close to the superior pole. You should not go higher up. If you go superiorly, there is a danger of injuring the external laryngeal nerve, and if you go still more superiorly, there is a danger of injuring even the internal laryngeal nerve. So, as close to the superior pole of thyroid gland, you have to ligate it. You should not do mass ligation. If it is having 3 or 4 branches, each individual branch has to be separated and then it should be ligated. By that only you will be very sure that you are not including the nerve in your ligature. So separate the artery branch all around and then take some time in dissection and put a ligature. Artery and vein should not be combined in the ligature. There are some reports wherein arteriovenous fistula have developed by ligating both the artery and vein together. So avoid doing that. Ligate individual branches of the artery, individual branches of the vein. There may be at most 3 or 4 branches. And actually you can do even bipolar diathermic coagulation. If there are any MS students, bipolar diathermic coagulation is sufficient to ligate these vessels. So you need not use a ligature. So whenever I do surgery on thyroid, I don't apply any ligature. I use only bipolar coagulation to do surgery for all the vessels of the thyroid gland. And this is the inferior thyroid artery. It is coming from the thyrocervical trunk. This is thyrocervical trunk coming from the subclavian artery, and it passes behind the common carotid artery and enters the thyroid gland, divides into multiple branches, and then enter the thyroid gland. And while it is going into the thyroid gland, these branches, they are very much closely related to the recurrent laryngeal. This is the recurrent laryngeal coming here. So this is passing in the tracheoesophageal groove. It's coming like this and passing behind the thyroid gland and going up like this, and then it enters the cricothyroid membrane and enters the larynx. So at this place, the recurrent laryngeal nerve is in a great danger. Yes, that's why the whole teaching was ligate the artery somewhere here, behind the carotid artery. You separate the carotid artery, so identify the inferior thyroid artery and then ligate it. So that's not a safe procedure now. Nowadays, what you do is you have to ligate the inferior thyroid artery branches individually. Where? Yes, I told you two capsules are there. One is true capsule of the thyroid gland, other is the facial capsule of the thyroid gland derived from the pretracheal fascia. So you have to tease away the pretracheal fascia here. So between the pretracheal fascia layer and true capsule, then you will identify the branches entering the thyroid gland. Individually, you ligate these branches. That is the safest way to protect the recurrent laryngeal nerve and protect the blood supply to the parathyroid glands. Of course, when we discuss about the parathyroid gland, I will tell more about the safeguarding parathyroid gland. The artery to the parathyroid gland comes from this inferior thyroid artery. Sometimes it comes from an anastomosing vessel between superior and inferior thyroid artery. Superior thyroid artery and inferior thyroid use of branches. These branches communicate. So from this communicating branch, a branch will come and supply the parathyroid glands. So this is the subclavian artery, this is thyrocervical trunk, and this is the inferior thyroid artery. The artery is being superior thyroid artery, branch from external thyroid artery. Okay, secure artery to the parathyroid gland while doing surgery. What I will do is, this is the question posed by one of the postgraduate students, and this is not, answer is not required for the undergraduate students. That is why now I won't tell it. After completion of this class, just I will take 5 minutes to show you a video how to protect this artery to the parathyroid gland while doing surgery. So the postgraduate students, if there are any, they can stay back and look at the video. And undergraduates also, if they are interested, they can look at that video. So once I finish this topic for the undergraduate students, so after the topic, I will tell today only, before we go there. Okay? Good. So the inferior thyroid artery, a branch of the thyrocervical trunk. So it is called the, of course, it is the artery supply. It supplies major blood supply to the thyroid gland. Thyroid branch, a branch from the aorta or occasionally from innominate. There are only 3% of the individuals. The venous drainage, superior thyroid vein drains to the intramuscular, the middle thyroid vein drains into the intramuscular vein, inferior thyroid vein into brachiocephalic vein. The lymph nodes. The main lymph drainage is to the pre-laryngeal and pre-tracheal lymph nodes. And some of the lymph, they drain along the superior thyroid artery, the inferior thyroid artery, and inferior thyroid veins. So the superior ones, they drain to the upper deep cervical lymph nodes. That is, they will drain into the level 2 and level 2 nodes, and those draining along the inferior thyroid artery, they drain to the level 3 lymph nodes. And from the upper deep cervical and lower deep cervical, and from pretracheal and prelaryngeal lymph nodes, ultimately the lymph will drain to the jugular trunk and then to the deep cervical lymph nodes, to right lymphatic duct and cervical lymphatic trunk. They drain to the ultimately thoracic duct. The thing to remember here is these lymph nodes, especially the pretracheal and prelaryngeal lymph nodes, have lymphatic communications with the substernal or mediastinal lymph nodes. So these mediastinal lymph nodes, sometimes they also are involved in thyroid malignancy. You have to remember that. Then these pretracheal lymph nodes and prelaryngeal lymph nodes, originally they were thought that their function is not known. Why they are situated there? It was not known. That's why they are called as the nodes of Delphicus or Delphian nodes. This word Delphius is derived from a Greek mythology. All the British saints, they borrow the names from Greek and Latin. They were the masters of culture in those days for the European countries. Of course, fortunately, we are the masters for our culture till about some 20 or 30 years before, but now our culture also is gradually being changed or eroded to Western culture. The British, they consider the Greek as their fathers of culture and science. That is why many of the medical terminology we find, they are all derived from Greek and Latin. Okay, this Delphicus means it is from Greek mythology, which means that actually the Greek god was there. One priest was doing some prayers. They put some dhupam there, smoke, a present smoke for the god. After inhaling the smoke, the priest who is there, he started speaking something. What he speaks and whatever he was speaking, no one else could understand. Then they simply said that, oh, Delphicus, Delphicus, Delphicus. Delphicus means something rubbish which is not known to, which cannot be understood by anyone. In vocabulary also you find some fellow speaking some language just like that. So Delphicus means something unknown and something is rubbish. So earlier surgeons and anatomists considered that the pretracheal and prelaryngeal lymph nodes have no significance. But now we know that most of the malignant thyroids which metastasize to the lymph nodes, they metastasize mostly to the pretracheal and prelaryngeal lymph nodes. That is why in all suspected papillary carcinomas of the thyroid, whenever you are doing surgery of total thyroidectomy, you must also include pretracheal and prelaryngeal lymph nodes in your dissection. That is called central compartment clearance. So that means these Delphicus nodes must be removed as a block along with thyroid gland. So that is the importance of Delphicus nodes. Though the name is derived from the unknown thing, but they have a lot of importance. Actually, this image depicts the various groups of lymph nodes. This is the submandibular lymph nodes. This is called the level 1 lymph nodes. These are the upper deep cervical lymph nodes situated above a line drawn at the level of hyoid bone. So this is the hyoid bone. So draw a line there. Above this line, posterior to the posterior belly of digastric. So these lymph nodes are called at the level 2. That's situated along the common carotid and intrajugular vein. Then you draw a line along the lower border of the cricoid cartilage. In between these two lines, the group of lymph nodes around the jugular chain is called the level 3 nodes. Then below this is the level 4 nodes. Posterior to the sternomastoid, that is posterior triangle lymph nodes, they are called the level 5 nodes. In the midline of the neck, submental and prelaryngeal and pretracheal lymph nodes. These are all called as the 6th compartment nodes. Already I told you the 6th compartment nodes has communication with the retrosternal lymph nodes or mediasternal lymph nodes. This is the level 7 lymph nodes. So thyroid gland drains mainly to the level 6. These are called the delphic nodes. Already I told you. Then there will be involvement of paratracheal nodes. From the posterior part of the thyroid gland, the lymph can drain to the paratracheal nodes. The nodes along superior and inferior thyroid veins, that is level 6. From there to deep cervical nodes, that is level 2, level 3, level 4, level 5, and mediastinal nodes. That means all the groups of lymph nodes in the neck, they are involved in the malignancy of the thyroid gland. That means the lymph is drained to all these lymph nodes. So the main lymphatic drainage is to the level 6 or medial compartment of the neck or central compartment of the neck. Histologically, when you dissect the thyroid gland, when you dissect the thyroid gland, so when you cut it and study under microscope, you will see multiple follicles. All these follicles are lined by epithelium. The epithelium will be either cuboidal, flat, or long columnar. And these follicles are filled with globulin. And this is called the thyroglobulin. Contains many lobules which are made of follicles. The follicles are structural and functional units of the thyroid gland. Each is lined by flat or columnar epithelium depending upon the activity of the gland and is filled with thyroglobulin where the hormones are stored. In between the follicles lie cluster of cells called parafollicular cells or C cells which secrete the calcitonin. Each is lined by flat or columnar epithelium or cuboidal epithelium even. It can be even cuboidal. So when will it be flat, when it is cuboidal, when it is columnar? Depending upon the functional activity of the thyroid gland, they may be flat, columnar, or cuboidal. Yes. If hyperfunctioning, they are cuboidal. If thyroidoscopy is there, they will be columnar. If they are resting phase, then they will be flat or squamous. So if the gland is more active, the cells are tall. If the gland is less active, the cells are short and stumpy and flat. Relations of the thyroid gland. This is very, very important. Superficially to the strap muscles and sternomastoid. What are the strap muscles? Already we seen. Sternum, thyroid. Deep to that, sternohyoid superficially, deep one, thyrohyoid and sternothyroid. Little lateral, we have the anterior belly or the superior belly of the omohyoid muscle. So these are strap muscles. And the anterior border of sternomastoid also form the superficial relationship. This is sternothyroid, this is thyrohyoid. Of course, thyroid is not related. Then this is sternohyoid muscle. Medial surface. The thyroid gland lies upon two tubes. What are they? The trachea and the esophagus. And two muscles, inferior constrictor and cricothyroids. And here is the cricothyroids muscle, and here is the inferior constrictor muscle. Hyperactivity can be cuboidal epithelium, or if it is more active, even columnar epithelium. Medially, there are two nerves are there, recurrent laryngeal nerve and external laryngeal nerve of the superior laryngeal nerve. On the posterior surface, that means this is the posterior surface of the gland. There is carotid sheath enclosing the common carotid artery and then intrajugular vein and of course the vagus nerve. And each lobe has superior and inferior parathyroid glands. That means each lobe has two parathyroid glands. And the Berry's ligaments. This is we are seeing the larynx from behind. Thyroid cartilage is like a shield in front, but if you look behind, it is open. So you can see the thyroid cartilage is open here. Cricoid cartilage is like a ring. So this is thyroid cartilage behind, and this is the ring of cricoid cartilage situated below. This is the epiglottis you are seeing here. This is the trachea. Tracheal rings are not completely present. They are present only laterally, anteriorly, posteriorly. You see tracheal muscle only. And here are the thyroid gland you are seeing here. The Berry's ligament is situated. Berry's ligament. What is Berry's ligament actually? Is it ligament actually or something else? Very good. Very good. It is condensation of the pretracheal fascia. We have seen the pretracheal fascia splits in two layers to enclose the thyroid gland. The deeper layer, because you are seeing from the posterior side, here is the deeper layer. The deeper layer of the pretracheal fascia condenses near the cricoid cartilage, and it binds the cricoid cartilage to the thyroid gland. So this is the Berry's ligament. What is the importance of Berry's ligament? Number one, it tightly binds it is a very short structure. It is only up about half centimeter. It tightly binds the thyroid gland to the cricoid cartilage. And with that, the thyroid gland moves unspirally. That is clinical point. Surgical point is this is the recurrent laryngeal nerve. The recurrent nerve passes in the tracheoesophageal groove, passes through the Berry's ligament, or courses over the Berry's ligament. It hooks over the upper border of the cricoid ring and enters the larynx by piercing the cricothyroid fascia. So if you can't find the recurrent nerve in thyroid surgery, what you should do is you should dissect the posterior side carefully to look at the berry segment. So definitely you will find the nerve coursing over there. In this part, the nerve may be little lateral, more medial, or more anterior, more posterior. But here in this region, it is very constant. And actually, just below the Berry's ligament, on the posterior border of the thyroid gland, you will find a small nodule-like projection. This nodule-like projection is situated just below the Berry's ligament. That is actually between the upper 2/3 and lower 1/3 of the thyroid gland on the posterior border. This small nodule is called as the tubercle. Can you tell me? Oh, wonderful. It is called as the tubercle of the Zuckerkandel. The Zuckerkandel is an anatomist. He has observed the relationship of the recurrent nerve now to this nodule. This is frequently present, and another landmark to detect the recurrent nerve now is this tubercle of Zuckerkandel. Or organ of Zuckerkandel is different. It is called as tubercle of Zuckerkandel. Organ of Zuckerkandel is nothing but a ganglion mass situated below the bifurcation of the aorta, where from a neuroblastoma and sometimes pheochromocytoma can arise. There is organ of Zuckerkandel. That is different. This is called the tubercle of Zuckerkandel. So don't get confused between these two. Okay. So this is the Berry's ligament. It is the area of greatest adherence of the gland to the larynx. It is condensation of the pretracheal fascia. It is also responsible for the movement of the thyroid gland during deglutition. Already I told you the most important points about the thyroid gland is not thyroid gland itself, its relation to the nerves. So this is the inferior thyroid nerve, which is related to the inferior thyroid artery. And here is the external laryngeal nerve, which is related to the superior thyroid artery. This recurrent laryngeal nerve, while it is going upwards, it gives off multiple branches to the esophagus and to the trachea also. And it gives two larger branches just behind the thyroid gland. So you don't find a single nerve there. You find a nerve which is giving off small branches here and there. Recurrent laryngeal nerve ascends into the neck by hooking around the right subclavian artery on the right side and around the arch of the aorta on the left side. It passes upwards to enter into the larynx by passing behind the cricothyroid muscle. During its course, it lies mostly in the tracheoesophageal groove and is closely related to the thyroid gland at three places. So this is very important. One, at the inferior pole of the thyroid gland. Two, is closely related to the inferior thyroid artery. It may pass anterior, posterior, or interdistate with branches of the inferior thyroid artery. And third place is at the attachment of Berry's ligament to the thyroid gland. So these are the three places where the recurrent laryngeal nerve is intimately related to the thyroid gland and is a danger during surgery of the thyroid gland. So this is the most important slide. So all of you must remember, and postgraduate students will have a question on this invariably whenever they come across a case of a thyroid gland swelling. The right recurrent nerve may be non-recurrent in 0.5 to 1% of the individuals, where it courses obliquely from behind to reach the larynx and may not be related to the thyroid gland in such an occasion. course, I'll explain it in the next slide. The left non-rectal nerve is rare but has been reported. Now you can see here, this is the trachea, this is the larynx, and here is the esophagus. This is the thyroid gland lobe, one lobe on one side. This is the inferior thyroid artery, dividing into branches and supplying the thyroid gland. And here is the superior thyroid artery coming down. So imagine the patient is supine position. Okay? And here is the recurrent laryngeal nerve. So the artery is going like this. Medial to the artery, the nerve is traveling in this image. Here you can see the nerve is coursing lateral to the artery, superficial to the artery. And here it is going in between the branches. It is deep to one branch and superficial to another branch. So it will go in between the branches. And in this place, the nerve is not in tracheoesophageal groove. It is over the trachea. It passes over the trachea, then passes along the posterior border of the thyroid gland, and then disappears into the larynx. So its position may be variable in relation to the inferior thyroid artery. So that's why there is no constant relationship to the inferior thyroid artery. You must always search for the nerve, look at the nerve, protect the nerve, and then do ligate the inferior thyroid artery. That is the only safest way by which you can protect this nerve. So this is recurrent nerve. We have seen that vagus nerve comes like this downwards, while it's coursing in front of the subclavian artery, it gives some recurrent laryngeal nerve. Why it's called recurrent? Because its neurological fibers, the axons, they come from the brain superiorly in the vagus nerve. It comes like this, and they again reverse back and go like this. That's why it is called recurrent. It loops and again passes superior. That's why it's called recurrent nerve. Sometimes it's not recurrent nerve. It is a non-recurrent nerve. Now we have seen that the superior I got the past. Okay. Now you see here, this is the vagus nerve, and here the recurrent is arising and it's again going superiorly. That's why we call this recurrent. Sometimes what happens is from here in the vagus, it comes like this and supplies like this to the thyroid. So then there is no question of it being in the tracheoesophageal groove. It comes obliquely from the vagus and descends down like this and enters the larynx. So it is not at all dangerous in such cases. So sometimes when you search for the nerve and if you cannot find the nerve, then you must think of a non-recurrent laryngeal nerve and look for it at the berry segment. Berry segment is constant there. The relationship with the berry segment is constant whether it is recurrent or non-recurrent. So look at the berry segment. If you find the non-recurrent laryngeal nerve, then you are pretty sure that there is no recurrent cause and you can proceed safely and then do surgery. Then superior laryngeal nerve. It is a branch from the vagus, descends medial to the internal carotid artery. At the level of the great horn of the hyoid bone, the superior laryngeal nerve divides into external laryngeal and internal laryngeal. It descends to the superior pole of the thyroid gland and travels medially along the inferior constrictor muscle in the space of ribs. Of course, undergraduate students need not bother about the space of ribs, but postgraduate students, they should know about it. It innervates the cricothyroids muscle, which is the tensor of the vocal cord. So this is the picture to show you the space of Reeves. This is the pole of the thyroid gland, sorry, lobe of the thyroid gland. This is the thyroid cartilage, and here is the cricoid cartilage, and this is the cricothyroides muscle. Yes, this I am describing about space of Reeves. This is the cricothyroides muscle. Okay, I hope you are appreciating. This is thyroid cartilage. This is cricoid cartilage. In between this is the cricothyroides muscle, and here is the lobe of the thyroid gland. If you hold the superior pole of the thyroid gland and retract it medially, laterally and downwards, then what? The loose areolar space between the cricothyroides muscle and thyroid gland is called the space of Reeves or cave of Reeves. The importance of this cave of Reeves is the external laryngeal nerve traverses through this cave of Reeves. So it is close to the superior thyroid artery near its origin. As it descends down, it goes more medially. The artery, if you like at the individual branches, close to the close to the thyroid gland, the nerve is not in danger. That's why what you must do is, you hold the superior pole of the thyroid gland, retract it away from the trachea and larynx. Then you will find a loose areolar space between the thyroid gland and the thyroid cartilage. That is the space of Reeves. In this space of Reeves, close to the larynx or the thyroid cartilage and over the cricothyroids muscle, you will notice this now. So this cave of Reeves is nothing but the loose areolar tissue that lies behind the medial surface of the thyroid gland and the outer surface of the cricothyroids muscle and thyroid cartilage. It has the external laryngeal nerve. Hope I am clear. Okay, before we conclude the anatomy, just look at the briefly about the anatomical points of clinical interest. Gland is enclosed in the pretracheal fascia, that's why it moves with swallowing. Pretracheal fascia arises from the fascia colli on the deeper surface of the sternomastoid. Hence, thyroid swelling is situated deep in the sternomastoid, however large it may be. Pretracheal fascia extends down into superior mediastinum in front of the great vessels, and hence an enlarged diameter can extend retrosternally. The gland is related to recurrent laryngeal nerve on the medial side. So hoarseness of voice can occur in malignant infiltration of the thyroid gland to the nerve. The gland is related to trachea and esophagus. So there may be dyspnea and dysphagia in malignant thyroid infiltration. This is the thyroid gland. So this is swelling of the front of the neck on one side. When the patient is asked to swallow, you can see the distance between the clavicle and the gland here, and the clavicle and the gland here. So it's slightly moved upwards. That means it moves up on swallowing. Of course, I need not demonstrate you the clinical sign of movement on swallowing. Now, one doubt is there for one student, that is middle thyroid being present in all the patients? Yes, 99% of the patients, they have middle thyroid being. Sometimes the lobe is very grossly enlarged, and the posterior border of the lobe, for example, this is the thyroid lobe. This is the inferior internal jugular vein. So it courses close to the internal jugular vein. then in that case, the vein will be very short, just 2 or 3 millimeters. You may consider that the vein is absent in such cases. It's not like that. The vein is always present and is very short in large goiters. That's why large goiters you must be very careful while you are mobilizing the posterior part of the thyroid gland. The anatomical points of clinical interest. Next, we'll continue then. Related to carotid vessels on its posterior border. We have seen the posterior border lies over the carotid sheath. That's why it gives the sign of Berry's sign. I hope all of you know how to exit Berry's sign. Anyway, I will just explain it. This is the pretracheal fascia. This is the prevertebral fascia. This is the sternomastoid muscle. Here is the carotid artery and interjugular vein, trachea and esophagus, and here is the thyroid gland. Now the thyroid gland enlarges, one lobe enlarges. While the gland is enlarging, it gradually pushes the carotid vessels and interjugular vein backwards. If it is due to benign swelling. How a benign swelling increases in size, how a malignant swelling increases in size. Can you tell me? How a benign swelling enlarges, how a malignant swelling enlarges. Method. Okay, benign slow enlargement, capsule is plain, that's okay. Benign swelling, what happens is, its cells continues to divide, but confined to basement membrane. That's why in benign swelling, what happens is, the organ or the gland gradually expands in size. When it's expanding, it pushes the neighboring structures outside. It pushes it out. But the malignant swelling, when it enlarges, not only by division of cells, but the cells won't stay there. They will pass in between the basal membrane and goes deeper and goes to surrounding structures, and that's called infiltration. So benign swellings, they grow by expansion. Malignant swellings, they grow by infiltration. So you can see this example very clear here. This is the benign swelling. It is expanding, so it has pushed the carotid and interjugular vein behind. This is malignant swelling, which is enlarging in size, so it engulfs, it infiltrates the structure that comes there. That means the carotid vessel is here only. It is not pushed. It actually infiltrated the carotid sheath, and then it has passed even behind that. Now, what is Berry's sign? What you do is, a patient with an enlarged lobe, you palpate the carotid vessels at the posterior, just behind the posterior border of the thyroid gland swelling. This is the thyroid gland swelling. Are you able to appreciate this image? My fingers are situated just behind the posterior border of the thyroid gland swelling. And you feel the pulsations. If you can feel the carotid pulsations for a swelling of the thyroid gland, what is your clinical judgment? If you can't feel the pulsations, then what is your conclusion? Pulsations are felt means what? Yes, very good. Benign pulsations present or absent? Yes, malignant you can't feel the pulsations. Benign you can feel. You can see here, benign and pushed. That's why keep your finger here. You can feel the pulsation. Malignant, It has engulfed the carotid sheath. That's why when you keep your fingers here, you can't. The thyroid gland will come in the way. That's why you can't feel the pulsations. So this is called Berry's sign. Berry's sign positive means carotid pulse not felt. That means it is malignant thyroid. Now let's discuss about anatomical points of surgical interest. Related to recurrent laryngeal nerve, may get injured while ligating inferior thyroid artery. Okay, someone is asking about the ligation of middle thyroid vein. Why? Just I will tell after finishing this one. Related to external laryngeal nerve, may get injured while ligating superior thyroid artery. Presence of parathyroid glands at the posterior border. When you remove the whole thyroid gland without making an attempt to preserve the parathyroid glands also come away along with thyroid gland. So when you are performing total thyroidectomy, all the 4 parathyroid glands also will be removed along with the thyroid gland. That's why in any case of thyroidectomy, either hemithyroidectomy or total thyroidectomy or subtotal thyroidectomy, you must always, underline, always preserve all the 4 parathyroid glands. That is one of the rules of thyroid surgery. So please remember, thyroid surgery means you must preserve both the laryngeal nerves and all the 4 parathyroid glands. Otherwise, the patients will get what will happen when parathyroid gland is removed. They will go into hypoparathyroidism. That means what is the clinical manifestation of hypoparathyroidism? How it manifests? Okay, Chostek sign and tetany. Calcium imbalance. Please specify what type of calcium imbalance? Okay, calcemia. Okay, hypocalcemia. Very good. So there will be disordered calcium metabolism producing hypocalcemia, which can manifest with various signs. It can manifest as tetany. It can manifest. Subclinical tetany is manifested by the Chostek sign. That means if you tap the facial nerve, the patient will get tics or spasms of the facial muscles. That is called the Chostek sign. Then if you apply a sphygmomanometer cuff around the arm and then if you inflate it just between the systolic and diastolic pressure, the patient will get carpopedal spasm. That's called so-called the obstetrician's hand. And because of hypocalcemia, patients will have numbness, tingling sensation, and paresthesia. So actually, there will be perioral paresthesia. Then, within few seconds or few minutes, patient will get tetany. This can manifest on 2nd, 3rd, or 4th postoperative day after surgery. In severe case of tetany, patients can get respiratory distress and conduction abnormalities in the myocardium. Because calcium is one of the important ion for the conduction of the cardiac muscle. Very good. Some students are asking me about the operative surgery related doubts. So I will answer those doubts after finishing this anatomy part. For this is a small video about the constitution of the larynx, how the larynx is constituted, and how the various intrinsic muscles of the larynx work, and how the vocal cord movements occur. Actually, all these details are not very much necessary for a surgical student, but an ENT student, of course, should know about this. And those who are very much interested to know how hoarseness of voice occurs, how the tone of the voice is lost in case of external laryngeal paralysis, then this video may be helpful. So if you want me to show, I will demonstrate this video. Otherwise, I will skip this video and go to the next topic. Shall I show you this video? Yes or no? Next slide. Okay. Okay. So that is about the physical anatomy of the thyroid gland. Now, some people have asked some doubts. Number one is, why should we ligate the middle thyroid vein in the beginning itself? So whenever you are doing surgery for the thyroid gland, there will be strap muscles into there, and we retract the strap muscles, and then you have to do surgery. What you are seeing, once you retract the strap muscles, you see this much of thyroid gland lobe, and this is covered by the plexus of veins from the thyroid gland. You have to remove the whole thyroid lobe. That means there is something on the posterior side, there is something on the medial side. This whole lobe has to be mobilized. How to mobilize it? On the medial side, there is isthmus. That's why you can't do it on the medial side. So the best thing is to mobilize from the lateral border of the thyroid gland. So to mobilize from the lateral side means you have to cut this vein. This is middle thyroid vein. If you cut this middle thyroid vein, then this whole lateral border is completely free. There is no vascular structure here. So you can apply a Babcock's forceps here and pull it towards medial side, and loose airway tissue will be there. You can dissect it by blunt dissection. So that is why middle thyroid vein is the structure that is ligated and first ligated and cut in the first attempt. So the other structures, other inferior thyroid artery, superior thyroid artery, and veins, etc., are ligated later. So the first structure that is ligated and cut is the middle thyroid vein. It is not to prevent air embolism. Someone has raised this question: air embolism in thyroid surgery. First of all, why air embolism can occur? Can occur. Not it is a rule in every case of thyroid surgery. It can occur in thyroid surgery. Why? Tell me. Rose position means I cannot get this point. Before that, I will pose another question to you. What is the pressure in the veins, in the intrajugular vein and its tributaries? What is the pressure? Pressure in the intrajugular vein, 25, 15 millimeters of mercury, 5 to 10 millimeters of mercury, 5 mm. Okay. It is very simple to tell about pressure in any vein in the body, because The venous blood is not pumped by any structure. For arterial blood, heart is pumping. That's why there is pressure. For the venous blood, nothing is pressing it out. Only the calf muscles do the peripheral pumping. So the blood from lower extremities will come against gravity into the heart by pumping of the calf muscles and muscles of the thigh. The upper limb veins, head and neck veins, they drain simply by gravity. Draining by simply by gravity means what you understand it. When the person is in erect posture, what is the pressure in the neck veins? For example, the pressure in the superior vena cava is 0 millimeters of mercury at the magnum sterni. Then what is the pressure at this place? For example, you take the intraocular vein at the superior part of the thyroid cartilage. So what is the pressure? At this level, it is 0. At level of magnum sterni, it is 0. So at level of superior part of thyroid cartilage, what will be the pressure in the intraocular vein? Is it +1, +2, +3, +4, +5, or -1, -2, -3, -4, -5? That's one wrong. Use common sense. Heart is here, vessels are coming from here. The person is in standing or erect position. You pour water into this tube. What will happen? The water will go into this chamber. Isn't it? That means its pressure is less than that is in heart. The person is lying supine. The pressure in the heart and pressure in the intraocular vein is same. If the heart is here, so the heart is here and person is raising the head like this, the blood will flow easily like this. That means the pressure is minus. That means if it is here and here, the distance is about 3 centimeters means the pressure here is -3 centimeters. The person is lying supine, flat. It will be 0. That means both will be 0. It is here 0, here also it is 0. If the person is keeping the head down, their pressure is increased. Did you get this point? The heart is here, this is head and neck, let us suppose. I will analyze this. Okay, the heart is here, this is head and neck. Both are in same level. The pressure is equal. That means if it is 0 here, this is also 0. The head is elevated. The pressure becomes minus. Or the body is like this. By gravity, blood is flowing down easily. So the pressure will be minus. For example, if this is manual sternite, it's 0. Pressure here, it will be -1, -2, -3, -4. If the patient is in erect posture, our head up, the head is down, then the pressure will be +1, +2, +3, +4. As you go down, the pressure is increasing. Near the heart, it will be 0. Then afterwards, gradually pressure increases because of dependency. Can you understand this point now? That is why a person with head injury comes to you. If you keep the patient in head up position, the cranial sinuses are open, intracranial sinuses are open to the outside. They can suck air through the cranial sinuses because in upright posture, the cranial sinuses will be having -6 to -10 centimeters of water of pressure, minus. So the veins will suck away the air inside. When you are doing thyroid surgery, what the surgeons will follow is they will keep the head end elevated. So when they keep the head end elevated, the Pressure in the neck veins will be at minus level. So when you open any vein, there will not be any bleeding. So because of that point, the surgeons keep the head elevated. So there is a problem with that. That means there will be a negative side pressure. So they can suck all negative side pressure, they will suck in air. So the air will be sucked inside and can produce air embolism. So most of the surgeons who are well experienced in thyroid surgery do not keep the head to upright position. They keep it in flat position or slightly elevated. That's all. Not more than 5 degrees. If you elevate the head more than 5 degrees means there is risk of air embolism whenever a small vein is injured, be it middle thyroid vein or inferior thyroid vein or any vein in the neck. If it is injured and open, means there is a chance of air embolism. It is not by extending the neck. Extending the neck means this is extension. Elevation means head end is in upside, that is elevated, head end position. We extend the neck to get the space. So the patient is supine like this, but the head is tilted down so that the trachea is bounced upwards like this. So patient is again supine, sorry, the same flat position. The occiput is down, the neck is thrown forwards, the thyroid gland more prominent seen, so you can do surgery very easily. If you keep the table like this in tilt position, this is head up position. Head up, but neck extended. Don't confuse between extension and head raised position. Did you get the point? Okay, wonderful. So that is about middle thyroid vein. Middle thyroid vein is ligated first because of convenience. To mobilize the gland from the lateral and posterior side, you have to first get a space. So that space is acquired by ligating the middle thyroid vein. Okay. So the other doubt regarding the parathyroid glands. How we safeguard parathyroid glands? I hope you are seeing the slides. Now you can see here the parathyroid gland. The parathyroid gland gets the blood supply from the inferior thyroid artery or from an anastomotic channel that communicates between the superior and inferior thyroid artery, and also from superior thyroid artery from the superior parathyroid gland. Now, when you are doing surgery, you are always safeguard, your attention will be most of the times about the recurrent lesion now and safeguarding it. But you also keep in mind about the safeguarding parathyroid glands. Sometimes you will safeguard parathyroid gland, but you will make it avascular by injuring its blood supply. So what we have to do is, we have to do subcapsular dissection. I told you this parathyroid gland is having the thyroid gland is having two layers of fascia, the outer layer of pretracheal fascia and inner layer of pretracheal fascia. The inner layer of pretracheal fascia is closely admixed with the gland parenchyma. So gland is having two layers of fascia. what you must do is the outer capsule has to be in size, dissected off the thyroid gland, and you must hold the parathyroid gland and dissect it safely from the thyroid gland along with this blood supply. Now I will show you a video regarding this. On. Just I'm trying to get the video onto the screen. Because the whole therapy will take about some 30 minutes. That's why I'm just focusing at the place where you can find the recurrent engine of saving and then parathyroid gland. Is it okay? Okay, you can see here, this is the inferior thyroid artery. I am dissecting the inferior thyroid artery. You can see here the recurrent laryngeal nerve coursing. Are you able to see it now? And that is the individual branches I am separating from the inferior thyroid artery. So there is one branch, and actually you can see here the inferior thyroid artery. Just I will pass it, and so you can see this is the recurrent laryngeal nerve, and my artery forceps is there behind the branch of inferior thyroid artery. The inferior thyroid artery is going like this. Recurrent laryngeal nerve is coursing in front of the inferior thyroid artery branch. Are you able to appreciate? Are you able to see the video now? You can't see any video? Wait, just wait. Stop showing. Just check and tell me whether you are able to appreciate the video or not. Oh, okay, see? Okay, very good. I'll play it now, you can see. So this is the recurrent laryngeal now. This is the inferior thyroid artery. This is the inferior thyroid artery. Sandy, you please refresh your video once. Refresh your page, because everyone else is able to see. You are only not able to see. There is some problem with your network or something like that. What you do is you stop screen share sometime and then again switch it on. Or you go to the refresh button and refresh it. On the laptop. Okay. And now I'll play the video. You just see it. If you want to have the full video, we will have an exclusive session for that in one class. Because it will be around some 30 to 40 minutes. And description means again it will take another 15 minutes. So it will be total 1 hour. So the complete video of the thyroidectomy operation I can demonstrate to you. But at the present, my main concern is to show you about the anatomy of recurrent laryngeal nerve and how to save it, and how to save the parathyroid glands by doing a capsular dissection. Okay? Now you can watch here the recurrent laryngeal nerve here, and this is the inferior thyroid artery. I am insinuating the artery forceps behind the branch of the inferior thyroid artery and separating it. So that is the inferior thyroid artery branch. I have put a loop here with the thread over that for the main branch. So the nerve you can see, I think, is glistening. Are you able to appreciate? So just away from the nerve, I am ligating the branch of the inferior thyroid artery. Now I think we can appreciate the nerve very much. Actually, in this case, the nerve is passing between the branches of the inferior thyroid artery. For you to appreciate, I am ligating each vessel, but usually what I do is I coagulate them with bipolar diathermy forceps. So this is the nerve. Now I am placing the artery forces between the nerve and one branch, because the nerve is coursing superficial to the branch here and going deep to the other branch. That means it is going in between the branches. You can see that is the main inferior thyroid artery, and that is the nerve I am showing. So there is one branch. So I am separating the branch. I hope you can appreciate the nerve and the one branch of the inferior thyroid which is going deep to the nerve. If you have not observed the nerve, you would have easily damaged the nerve in this case. Once we ligate the vessel, the blood supply coming to the gland from that source will be absent. So whenever you want to remove a gland or a structure, you must deprive it of all the supplying blood vessels. Whichever blood vessel is there, that blood vessel should be ligated. The blood vessel after ligating, it clots and clot organages, and afterwards it becomes a fibrous band. Now, that is parathyroid gland I am holding. Just I will go back. Now I am holding the parathyroid gland. And that one is parathyroid gland. And you have to separate it from the capsule. This is the parathyroid gland. So you should have the capsule. You just go underneath this capsule and separate from the thyroid gland and keep it away. You should have the blood supply. This small vessel is going there from the inferior thyroid artery branch. If you ligate the main thyroid artery, main inferior thyroid artery, the blood supply to this one also will be impaired. That's why you must go and ligate the branches of the inferior thyroid artery as close to the thyroid gland as possible, so that you can spare the vessel that's going to the parathyroid gland. Of course, the rest of surgery is ligation of superior thyroid artery and then removing the gland of separating from the trachea and various ligaments. Now I am ligating superior thyroid artery branches. So I will stop it here. Any doubts? Okay. If you have no more doubts, I will close this session. What class do you want for tomorrow? If you have any specific thing, just tell me. I will talk about that particular one. Or else I will choose some topic and then I will inform you by email. Do you want any topic from general or systemic? Okay. If you have nothing in your mind, I will let you know about the topic. You want hernia? Okay, hernia is a very big topic. Which part you want? Any inguinal hernia, recurrent hernias, or incisional hernia, femoral hernia, obturator hernia? Which hernia you want? Inguinal hernia. Okay. General features of hernia. Okay. Management of hernia means unless you know about the pathology of hernia and anatomy of the concerned area, you cannot understand the management. So that is why I will touch upon the general features of hernia and tell you something about inguinal hernia if time permits. Yes, I will tell you about the anatomy of hernia, the general features of hernia in general, and then about the inguinal canal, anatomy and hernia. So as much of time as possible, I will go with that. Okay? Okay. Good night. See you tomorrow again at 4 p.m. So we'll talk about the hernia. Thank you. Good night.